Okay, thank you very much. Thanks for the invitation to give this talk, and thank you to Bear to talk on this topic, related to the prior talks, but somewhat different, and I think it's also very topical given the recent approval for gadolinium use for cardiac MRI. So I'm going to talk about the optimization of contrast use for cardiac MR. This is a disclaimer slide just from Bear, just stating that you need to read the package insert when using gadobutrol. So if we talk about the basic cardiac MR protocol, I always tell our students that it really is basic. It's a combination of cine MRI, you inject the contrast, and approximately 15 minutes after the contrast injection, by convention, you do your late gadolinium enhancement. That's how cardiac MR has been done for the last 20 plus years. The original research was based on this protocol. And you can see in this set of images, here's a patient with multiple infarcts. You can see lots of scar in multiple areas of the myocardium, complicated by mural thrombus. And when you look at the contrast injection, I'm giving you a range there because there really isn't a complete agreement on how much contrast you inject. But when you inject the contrast, most people still image at about 15 plus image post-contrast injection, hence the term late gadolinium enhancement. And then in addition to the conventional protocol, we have multiple newer techniques that we now add into our protocol, and these are all listed here. And many of you have seen this in this particular conference. Many of the techniques are featured here, but of particular interest are the mapping techniques, which are now entering the mainstream, particularly T1 mapping and extracellular volume quantification for evaluation of interstitial myocardial scar. So schematically, when we look at the standard protocol, it's set out here. We start with the scouts, we do our cine MRI, and then we do delayed enhanced imaging. We typically inject the contrast not after the full set of cine imaging, but usually before we do the short axis acquisition. This is mainly just to speed up the protocol because we don't want to build too much dead time into the protocol. So if we're waiting 15 minutes with no acquisition, that's just a waste of time on the scanner. And then following the cine images, or following the injection, I should say here, we do our late gadolinium enhancement at about 5 to 30 minutes. I'm giving a wider range here. And then we can add in into this protocol mapping and flow imaging as well, either post-contrast or even pre-contrast. Most people do post-contrast for flow imaging because the image quality is better. When we look at the timing of the contrast injection, you can see that normal myocardium washes in and out contrast, but when we do late gadolinium enhancement, we wait, again, this period post-contrast injection, we wait for the gadolinium to really dissociate, or not dissociate, but go out into the interstitial space where the gadolinium is retained. And you see subendocardial enhancement here on these late gadolinium enhancements shown in the infralateral wall. And the pulse sequence that's generally used is a segmented inversion recovery turboflash. In most instances now, phase-sensitive inversion recovery reconstruction is used. So this obviates the need for any particular TI scout or timing mechanism for measuring the inversion time. So what are the recommendations for late gadolinium enhancement? And these really are my recommendations. Late gadolinium enhancement is necessary for most cardiac MR indications. We've seen some non-contrast approaches, but contrast enhancement is really required for most evaluation. You really need to use an inversion recovery technique. So this is IR-TFL or IR-SSFP. The recommendations are to inject about 0.1 to 0.2 millimoles per kilogram of GAD. We image at 5 to 30 minutes post-injection. And then late gadolinium enhancement visualization really depends on the technique, as I mentioned, and you use the IR-TFL, but this is somewhat simplified now because this technique uses PSIR. And really, there's not much dependency on the inversion time anymore. But also visualization depends on dose, relaxivity, and the delay post-injection. So I'm going to allude and talk a little bit about some of these studies which try to address when to image the heart post-gadolinium injection and when late gadolinium enhancement should be imaged. So if you look at some older studies, here's a study comparing single-dose gadabutrol to double-dose gadopentanate, where they measured scar with both techniques. And you can see that the scar quantification by volume and also by percentage was pretty comparable between whether you used a single dose of a high relaxivity agent versus a double dose of a standard relaxivity agent. And this is a study from over 5 years ago now showing this. Another more recent study looked at different doses at different time points. So they imaged the same group of patients, first with a single dose of gadabutrol, and second, they repeated with a double dose of gadabutrol and imaged it at different time points post-injection, and found that when you used the lower dose, the 0.1 millimoles per kilogram, they got maximum contrast to noise typically at 10 minutes post-injection, but when they used the larger dose, 0.2 millimoles per kilogram, they found the highest contrast to noise at about 20 minutes post-injection, so at a longer time period post-injection, which fits with some of our conventional late gadolinium enhancement approach, except that it's later for the higher dose, but potentially suggests that you should be imaging earlier if you use a lower dose of contrast. And when you look at a number of the larger cohort studies which have been published, and this is again one more recently from 2018, looking at the Iceland MI cohort, which used a single dose of gadopentanate, you see that you get pretty good results in terms of outcomes. And a lot of the large cohort studies are, in fact, using single-dose gadolinium, and it is based on the visualization of scar for predicting adverse outcomes over time. So what about the second biggest indication for injecting contrast for a cardiac MR protocol? And this is myocardial perfusion. And the difference with what I showed already is that now you're imaging the heart during the first pass injection of a contrast bolus. So you have to image when the heart is being injected, and this is also combined with late gadolinium enhancement. The difference here is that you also your timing is a little bit different, because you may want to time your late gadolinium enhancement to the point of your first injection of contrast. And this is set out here. So for a stress perfusion protocol, you typically will do your stress perfusion first with your vasodilator, then you do your cine imaging, then you do your rest perfusion with the second half of the contrast bolus, and then your late gadolinium enhancement. So the question is, when should you do your late gadolinium enhancement? And if you're using a lower dose protocol, which is what many people are using now, you may want to do your late gadolinium enhancement immediately after your rest perfusion protocol, because that's going to be within about 10 to 15 minutes of your first injection of gadolinium. This is what a CMR perfusion set of images look like. Stress images are on the top, rest images are on the bottom. This is a study from our institution, and you can see here a defect in the inferior wall of the heart, very clearly seen on the stress images, which goes away at rest, and there's no scar imaging on the late gadolinium enhancement images. So this is a positive stress protocol, likely with ischemia in the right coronary artery territory, and this is with a dose of 0.15 millimoles per kilogram of gadabutrol. Now, there are many studies published in the literature looking at CMR perfusion, and this is summarized in this review article by Schwitter and Arai, and all the references for these studies are actually listed in this paper for your reference. But in summary here, you can see that many studies are carried out at 0.1 millimoles per kilogram. Some are carried out at 0.2 millimoles per kilogram, but the results are pretty much comparable. They all pretty much get sensitivities and specificities in the mid-80s to the low 90s, irrespective of what total dose of gadolinium you use. More recently, a landmark paper just published in the New England Journal of Medicine looked at compared 918 patients in a multi-vendor study at 1.5 T, and they divided the cohort into an MR revascularization protocol versus an FFR protocol, and they found that there was no difference in outcome between the MR-based approach and the FFR, which is an invasive approach. and actually found that there were fewer revascularizations with the CMR-based approach. This was carried out, again, with 0.15 millimoles per kilogram total dose of gadabutrol. And then some of the better-known papers for CMR perfusion. These are the CE Mark study on the left and the MR impact study on the right. The study on the left uses a single dose of gadolinium. The study on the right uses 0.15. And again, both of these were comparisons with nuclear, which found higher sensitivity and specificity compared to SPECT, but again, carried out with a slightly lower dose, total dose of gadolinium for perfusion. Finally, just finish up talking a little bit about mapping. Mapping is used now fairly, certainly talked about a lot in the literature, and has increasingly been used routinely for clinical cardiac MRI, mainly because of this parameter that we measure, which is extracellular volume mapping, which depends on the measurement of T1 pre and post contrast, both within the myocardium and the blood pool. This is a study, again, a clinical case from our institution using 0.15 millimoles per kilogram of gadabutrol, where ECV is of direct clinical use. So you can see a patient on the left, the cine image on the left showing left ventricular hypertrophy. There's no enhancement seen on the late gadolinium enhancement, but when you look at the ECV, it's 40%, which is pretty much pathognomonic of amyloidosis when you get values that high. But also bear in mind that you may get an abnormal ECV even when there's no late gadolinium enhancement seen. There are numerous studies published on ECV. This is the original study from Kelman, which showed differences in ECV for patients who had known myocardial infarction as well as hypertrophic cardiomyopathy. This was carried out with a total dose of 0.15 millimoles per kilogram of gadolinium TTPA. Also some other studies, interesting studies. One study here comparing patients with left ventricular hypertrophy to try and distinguish HCM from hypertension. They found that both native T1 and the ECV was able to distinguish HCM from hypertension, where the ECV was higher in the HCM patients. Also, another study where they looked at outcomes by using T1 and ECV in the native myocardium remote from the scarred myocardium, and found that the patients at a higher ECV in the remote normal myocardium had a worse prognosis over time. And this was carried out with a single dose of gadabutrol to measure the ECV post-contrast injection. So just to finish, gadabutrol is the agent now which has now been granted approval by the FDA just in July of this year. This is very exciting for the cardiac MR community, for those of you that do cardiac MR. And the label is to assess myocardial perfusion, both at stress and rest, and late gadolinium enhancement in adult patients with known or suspected CAD. And this was based off two multi-center trials, GADACAD-1 and GADACAD-2, which used a total single dose of gadolinium, a lower dose than what we normally think of by convention. I'll just add in this slide here, since we are at the MR Angio Club, and don't forget about MR angiography. And you might be wondering, when you do stress perfusion MR, and one of the speakers in the session this morning talked about MR angiography of the thoracic aorta. But if you do stress perfusion MRI, you pretty much blow your contrast dose, particularly if you're using low dose. This is a study we did at our institution comparing first pass MRA with gadabutrol to an equilibrium phase MRA on the right. So this is taking advantage of the high relaxivity of gadabutrol, where you can kind of simulate what we used to do with blood pool agents, but because you've got higher relaxivity, the agent sticks around quite a bit longer. And using an IR SSFP technique, you get comparable image quality, if not better image quality, to a first pass MRA, as shown on the left. But more notably, the measurements of dimensions with both techniques for aneurysms is pretty much nearly identical. So this is very useful. We use this routinely in our protocols when we have to measure or evaluate the thoracic aorta. So in conclusion, contrast-enhanced MR is necessary, I think, in my opinion, for most CMR indications, and can be carried out at lower doses of 0.1 millimoles per kilogram than we more conventionally think. Stress perfusion MR is the desired protocol for assessment of ischemic heart disease. It's been shown better than nuclear, and also can be carried out with a total lower dose of 0.1 millimoles per kilogram. Late gadolinium enhancement, if you are using a lower dose, which may become the more standard dose, should be probably carried out at an earlier time point of 5 to 15 minutes post-injection. And T1 mapping and ECV is now increasingly used for routine cardiac MR and can also be carried out at similarly lower doses as evidenced by the literature. So thank you for your attention.